Great. Thank you all very much for joining us. This is the ASCS Journal Club. We're kind of rounding out the year with Athletic Elbow. And we're really lucky to be joined by three of the sort of world's experts in this and really people that are pushing the envelope on taking care of one of the more difficult areas in athletes that we treat. So Drs. Eric Bowman, Peter Chalmers, and Michael Freehall are going to teach us a lot of these unsolved questions I think we all sort of wonder and try to figure out as we're taking care of these really tough overhead throwing athletes. Chris, do you want to say anything before we get started?
Yeah, so the success of these webinars are always based on the participation. So if you have any questions and you want to be anonymous, just message me directly, or if you want to just message the whole group, we'll make sure to field them to these experts. And thank you all for joining us.
So we'll have a note from our sponsor.
At Smith & Nephew, we strive to put solutions in your hands that can allow your patients to live a life unlimited, and the shoulder space is no different. Here at Smith & Nephew, our focus is on providing you options throughout your patient's continuum of care with cutting-edge products like Regeniten, a bioinductive implant that redefines biologic healing for rotator cuff tendon growth, and the new ATOS shoulder system starring the ATOS Metastem that allows for maximized stability and an elevated surgical experience with an efficient system to help simplify shoulder surgery. We are honored to support the ASDS Foundation, and it is our mission to continue to provide you with the most innovative solutions in the shoulder to help restore the patient's ability to live their life unlimited.
Perfect. Well, thank you all very much. So we're going to get started on the first article and the first sort of topic of this. So this is the one that's on the influence of the single 30-pitch session on elbow laxity. So Peter Chalmers, one of our panel's experts, is here for this study, and I'm going to summarize it real quick, and then I'll probably bump it to him to get us started on this journal club. So, the purpose was to evaluate the impact of a single session on the UCL thickness and laxity on ultrasound. Really kind of novel technique of looking at this. Looked at high school and collegiate pitchers, and they underwent an ultrasound before and then after a 30-pitch bullpen warm-up. They measured the sort of laxity, the distance between the ulna and trochlea with and without 5-pound weight in hand to sort of maximize the standardization between measurements, and doing it at 30 degrees of flexion. So 15 pitchers, 8 collegiate athletes or 8 collegiate pitchers and 7 high schoolers. The peak velocity that they could throw was 89, so anywhere from 77 to 98. And they collected a bunch of data about their prior pitchers, or what they currently average as far as pitch per game, and then what they average in previous season. So an average of 56 games, throwing around 62 pitches per game, but it varied from 25 to 140. So they got a really nice breakdown in that. And what they found is after throwing, there was less UCL laxity, and that the post-pitching laxity was associated with peak pitch velocity, which basically means that like the direct correlation between the ultrasound measurements and the actual velocity, as well as the average number of pitches thrown per game. And the idea of this study, or the conclusion of the study, was it was sort of this novel way of looking at the impact of pitching velocity, the number of pitches thrown on the UCL, particularly when you're looking at the flexor pronator activation, you're looking at the some of the controversy around the fatigue of the flexor pronator mass. And maybe helping us provide some evidence-based guidelines on workload management and when fatigue starts setting in. So really cool study, Peter. If you want to kick us off, maybe do you want to talk about, first off, what did you sort of learn from the study? What are the kind of next steps? How are you using this as a way to help with the people that you take care of?
Yeah, I mean, so this is the diagnosis and treatment of ulnar collateral ligament tears remains a subject of a lot of controversy. And diagnosis in particular has really changed a lot. I mean, I think historically, we were using MRI kind of as the sole method of diagnosing those tears, obviously in combination with your history and examination, but MRI was really the sole imaging study. Historically, there have been some use of trying to use stress radiographs, and there's an old paper by Jamie Andrews, and there's a more recent paper by Luke O, and both of them really show that doesn't really work that well. So based upon that, there are more recent efforts at stress. And the thing that's interesting about stress, and this, Eric, I'm curious to hear your feedback on, is we've known for a long time that the medial elbow is protected not just by the UCL, but also by the flexor pronator. And the flexor pronator is thought to be a defender of the medial elbow, but its role, like in vivo, and how important it is for stabilization, I think has always been a little bit unclear. So for me, the reason why that matters is because if the flexor pronator is really providing a lot of stabilization, then the question becomes, when we stress the elbow, are we stressing the ligament or are we stressing the flexor pronator? So that's the reason why I did this study, is because I wanted to see what happens when you activate or maybe fatigue the flexor pronator in terms of the laxity within the elbow. With the idea being that if that's a dynamic thing, laxity, then that may have a lot of effect on how we interpret that particular number and understanding whether that means the UCL is torn.
Yeah, no, that's fascinating. Yeah, Eric, what do you think? How are you interpreting the relationship between the flexor pronator activity, flexor pronator fatigue, and your diagnosis of these UCL, either risk or actual injuries themselves?
Sure. I think hats off to Peter for a great study here. Looking at this, I mean, in some ways it's kind of, reverse of what you would expect, right? As you're pitching, you would expect that as you fatigue, that distance would increase on ultrasound. And I think that what you're seeing is sort of a natural protective mechanism. And Peter kind of points this out in the study, is that you're probably getting increased activation of the dynamic stabilizers of the elbow, and that's really the key. We know that the UCL is going to natively tear around 33 Newton meters or so, and then and pitching gets up to over 50 Newton meters, and so with every throw you are essentially taking it to the limit. But we have these other constraints, the dynamic and bony constraints to the elbow, in addition to just the ligament, but those are certainly protecting it. So, Brandon did Peter did an interesting study a few years ago looking at the response of the UCL to stress. I don't know if you want to comment on that, Peter, but what you see over the season, I think that's really interesting for us to keep in mind in regards to ultrasound and what that can tell us.
Yeah, I mean, and part of the impetus for this is people are increasingly at our baseball meetings saying, "Oh, I'm using stress ultrasound to diagnose UCL tears and if the elbow gaps, that means the UCL is torn." I think our paper really shows that if you can get the UCL, the flexor pronator to activate, you can really resolve that gapping. And that's what we see, as Eric mentions. The other thing that I think the study shows is that at 30 pitches, you've not fatigued the flexor pronator. And to me, that's important. I mean, that suggests that there probably is a threshold workload under which the ligament is really protected. And that actually is reflected in our workload data from the commissioner's office, which suggests that up to about 3 innings, there's really not an increased risk for injury. It's beyond that where you start to get fatigue. And there's other studies that have done similar things to this study where they've looked at 45, 60, 90, more and more pitches that show that actually laxity starts to increase with more and more pitches. And that's the point at which I think you start to see more load borne by the ligament instead of the flexor pronator, and then the ligament tears. So I think this is similar to how we understand really all injuries, in that when muscular fatigue occurs, you can no longer protect the skeleton and the ligamentous structures, and then all of a sudden injury occurs. So that if we want to talk about prevention, we need to either push that fatigue out or keep our exercise within the limits of that fatigue.
So what's the
Eric,
future
how
then?
do you-
Oh, sorry, go ahead, Clifton.
I was just going to ask, how do you apply this data for adolescent athletes, right? So I think one of the longest, more painful conversations I ever have in my office is the mom and child pitching duo. How do you counsel them about workload as they age to prevent injury? Maybe
Well,
start Peter and then Eric.
Yeah, the next step for me in this work, and we're working on this, is to figure out how to optimize exercise programs for the flexor pronator. So when we've talked about UCL rehab, if you look at the programs, they're like whole body rehab programs, and I think those things are effective and those are important. But I think we've never really had a focus on the flexor pronator. We know from a lot of careful work that's been done largely in Asia using stress ultrasound, but also using oh my God, I can't believe what it's called. It's what you guys are using, Eric, where you look at the elastography. Yeah. Using elastography, that there are differences within the individual muscles in the flexor pronator and how well they protect the UCL. And I think that we could do a better job of improving those programs So the next steps for me, I think the future is to isolate which exercises best isolate those muscles and then design programs that are going to be optimum for protecting the UCL to maximize this effect that we see at 30 pitches and try and push it out to 60 pitches and 90 pitches and increase the endurance of our pitchers so that we can reduce injury rates. I don't know if that will work, but for me, it's at least a pathway that can make sense based upon this work.
Yeah, no, that's great. Eric, what about you? So, from a workload management, meaning identifying when the fatigue is setting in, or just kind of the next phase of this, are we going to have ultrasounds in the dugouts examining these gaps? Like, what do you see as the future of how we're going to sort of manage this in real time with these athletes, collegiate, professional, even high school?
Sure. I think so much is being done right now with as technology is allowing us to look biomechanically and with TrackMan and the other basically mechanics type technology that's out there. We can almost see kind of during a game when those mechanics begin to change. And I think, yeah, it's more than just the UCL, right? It's the whole kinetic chain, and as you start to see form change throughout the game, I think that's going to be predictive and helpful. Right now, at least the major league level, you're not allowed to use that data in game. But I would almost anticipate that at some level we're going to be able to say, yeah, you're take an individual pitcher, hey, your form is starting to break down, after 45 pitches, and then you can really, I mean, you can even with these markerless systems measure torque and that at the elbow. So I think that's what it's going to come down to, is really more of a biomechanical evaluation, real time. Once we're able to do that more widespread, of course, at the younger levels, you mentioned that's going to, it's going to take a long time to get there, but it's multifactorial. It's pitch intensity, not just number of pitches. It's pitch type and how much spin you're putting on the ball. So every time you're aggressively pronating or supinating, you're stressing that pronator, the backup stabilizers, and at some point they're going to fatigue, and then you throw in a velocity where you're driving that engine as hard as it can go with every pitch. That as that intensity level with every pitch kind of ramps up, we have to think about that at all levels. It's not just number of throws, number of pitches, hidden throws, as we talk about so much at the young level. It's the intensity. It's not taking a few months off per year. It's every time you're going out playing at near max. I think that's really what's driving a lot of these injuries that we're going to see kind of at all levels. But I think biomechanically, we're going to be able to identify some of these, at least at the higher levels going forward.
Yeah, no, that's fantastic. So let's say you have a kid that's starting to get some medial elbow pain, and well, how are you telling them? Maybe give a couple of points. What are you specifically saying? Like, you need to change this, you need to change that, try not to do this, etc. So maybe it's not a professional that they can do these fancy markerless studies. Maybe this is a kid that's in high school or even before that's starting to maybe clearly demonstrate some pain, medial elbow pain, but definitely not to the point where there's gapping and there's a tear.
Sure. I think and as Chris mentioned, these are the toughest group to work with, and just to or at least to educate them. But it's very rewarding. These are some of my favorite encounters, even though they can take a long time. Is that I think once they see that that you're interested in helping them not just get over their elbow pain now, but preventing injuries in the future, I think they're really going to key in on that. And basically, what I tell them is, it's a combination of rest. You gotta let it calm down, the inflammation calm down, etc. In the meantime, you don't just sit around playing Xbox. You get working on the other things. You demonstrate that they have pretty poor more than likely. They can't do a leg raise on the table without their back coming up. You have them do a single leg squat in the office, and very few high school boys can do that effectively. And so you start to point out these things and say, look, you're going to lose force basically as you get going from the ground up to the hand to release the ball. You're going to lose force at each of these steps. These are the things that you need to work on now. And then a few weeks from now, when some of the elbow pain has calmed down, then we can start working on mechanics. And for mechanically, for some of these kids, they have coaches, and unfortunately, a lot of the kids I work with, they don't. And so you have to kind of know some of the keywords, like, don't open up your chest as you're throwing. You don't want to have your arm. You don't want your arm to be slow or dropping. You want good shoulder and hip. You want good shoulder hip separation so that your torso is acting like a rubber band. These are some simple things that you can kind of cue them. I think that, yeah, getting them to calm down, getting them to focus on the other mechanical issues and deficiencies that they have, which are always there, addressing those first, and then gradually getting them back into a throwing program is a reasonable approach.
Fantastic.
Awesome. Well, I'll go to the next article, but I think before we move on, I think a lot of the younger members of this webinar would love to know, just briefly, how did you both build a throwing elbow practice? And it's not easy to do, so clearly there were steps.
That's a great question.
I think I'm still working on building it. So whatever tips Eric has, I probably could utilize them. But the things for me that were really important are that number one, I manage the university's baseball team as well as a minor league team here in town. And then the thing that I did is I went to all the therapists, and I went to, like, there's a local baseball academy, and I've tried to tell them, I'm going to do whatever I can to help the players that come to see me. And then I just gave my cell phone number to the guy that directs the baseball academy, and I say, you interact with these parents, you just give them my phone number and tell them they can call me. And it's interesting, almost no one ever calls me, but we still have patients in clinic because of it. I think it's a lot. Like, I think that you guys would agree that the number one thing that people want to know, that you're a member of the community and that you care, and that you're engaged with the community, and that you're not, you're here to do whatever you can to help. So part of that is that I see a lot of patients we treat non-operatively. I mean, I see, like, I probably treat 1 out of every 30 baseball shoulders operatively. I mean, we treat almost all those patients non-operatively. So if you're looking to build a busy surgical practice, I will tell you baseball shoulder is not the best place to start. You'd be much better served by seeing patients with glenohumeral osteoarthritis or rotator cuff tears. But that's not really what it's about. I'm not trying to be like the surgeon that only operates on everything they see. I mean, it's about an interest in this particular sport, and the community, I think, starts to understand that when you really start treating people that way.
Yeah, I'll echo everything Peter just said. I think it's just like anything. It's in building a practice. It's being available. It's giving your number out to trainers, coaches. If you're in an area and you're taking care of a high school team, show up to their games. Talk with your physical therapist about maybe doing some preseason screening where you just do a basic thing, just like I just described. You can do in clinic and say, hey, these are some deficiencies you can work on. Here's some exercises to go along with it. And if problems come up during the season, please reach out to us. We're here to help you. I think where you're going to get the bulk of your referrals are through people knowing other people that have come to you. But even probably more important early on is building those relationships with the trainers, and then the physical therapists. Like, if I know therapists that love baseball, and I send patients to them, and they vice versa will send back to me. So it's building that network that's helpful, I think.
Awesome. Those are great insights. I'm sure many of us would like to get the practice you all have, but I'm going to move on to another paper here. And it's actually, there's a common theme between the panelists here. They seem to have written every recent paper on baseball. So, I mean, congratulations to y'all. It's awesome stuff. So next one is, the title is elbow ulnar collateral ligament repair with suture augmentation is biomechanically equivalent to reconstruction and clinically demonstrates excellent outcomes, systematic review. The purpose of this paper was to systematic review biomechanical properties of augmented ulnar collateral ligament repairs, compare with reconstruction, and clinically complication rates of UCL repairs without augmentation. This was a systematic review, including studies that compared augmented repairs with reconstruction and clinical studies with outcomes at a minimum of 6 months follow-up. The biomechanical study showed that augmented repair demonstrated less gap formation with equivocal torsional stiffness, failure to load, peak torque compared with reconstruction. The clinical outcomes showed repair to play in patients without augmentation demonstrated a return to previous level of 50 and 94% for non-professional athletes and 29% for professional baseball players. Suture augmented repairs showed a return to previous levels of 92 to 96% at 2.9 months to about 7 months. The overall complication rate for augmented repair was 8.7, most commonly neuropraxia. So this study concluded that UCL repair with augmentation provide less gapping with equivalent torsional stiffness and failure compared with reconstruction. Augmented UCL repair demonstrated excellent return to previous level of play and modest complications and time to return. Augmented UCL repair is biomechanically equivalent in reconstruction to reconstruction and may be a viable alternative to reconstruction in indicated athletes. So Eric, you were the senior author on this paper. Love to just hear you comment your thoughts, because really interesting idea and really progressive thoughts.
Yeah, and thanks to my co-authors who helped me on it. I think, even taking a step back, and if you think about, or if you've listened to the lay press at all, you know that we're in the middle of a UCL epidemic, or numbers continue to rise. About a third, at least, of major league players have had UCL surgery. We know that is trickling down to the younger ages. And why is that happening? Well, certainly we know that velocity has a large part to play in that. You've seen the average velocity go up several miles per hour over the last several years. We know that workload plays a huge role, as Peter was mentioning. So, the number of teams that guys are playing for at the younger ages, the number of months per year, the intensity that they're playing with, specialization at even young ages, these designer pitches where you're putting, high amounts of spin on the ball, all that increases your workload. And then mechanics. We know that mechanics play a big role in this. And if you have poor mechanics, you're basically repeating the same bad movements over and over again. And that is all kind of adding up to what we're seeing now, which is an increase in UCL injuries. And what we know is that UCL reconstruction, it's a long recovery, right? It's up to 12, 14 months sometimes to get back. And so we've seen a trend towards more repairs, right? So these UCL repairs with this internal brace, which is basically a suture that's being used to augment the repair of the native tissue. We wanted to say, is what we're doing, is it legitimate here? Are we biomechanically and clinically replicating what we're seeing in reconstructions? Now, the big caveat with these is that these are two different groups of patients that get these surgeries. So it's not directly comparable. There's no head-to-head studies here. And I can get into a little bit of the differences between repair and reconstruction populations, but in general, we said biomechanically, are these equivalent? And we found, yes, gap formation was actually less. The peak torque and torque failure were very similar to reconstruction. So it seems to hold up from that side of things. And then clinically, as I mentioned, there's no head-to-head, but it had excellent return to sport and a much quicker return to sport time. So 7 months versus, that 12 to 14 months, about half the time. And we know that based on the data, that the complication rates are about the same. And that the revisions, just anecdotally, they're not as it's basically like you have a native UCL in a lot of cases, so you're not necessarily burning any bridges with the repair. So we can get them back quicker and basically have the same relative outcomes, then why not move to repair? And so that was basically what we found in the study, is that, yeah, biomechanically it holds up, clinically it holds up. And the big difference is the populations, right? So to do a repair, you really need to have viable tissue to repair back, right? So if the tissue isn't good, it's, you're wasting your time trying to repair it. We've through some of the studies that Peter and I are part of a study group, the Cutter study group, and we're looking at some of these questions like what is good tissue and what on MRI do we agree about? In one of the studies that we looked at, we said that mid-substance tears are probably a contraindication to repair. So if it's torn in the middle, you've lost continuity, so that's probably not a good repairable state. If you're missing tissue, so sometimes you get these ossicles or you get these tears and they just aren't going to reach back. If you're missing tissue, those probably aren't good ones to repair. And then we don't know what this looks like at the higher levels. So not many have been done at the professional level, and they're starting to trickle up there. We don't know the longevity. So the first couple of years look pretty good, but we really need to follow these out so that we can say that what the true clinical implications are of doing these repairs at higher level athletes. And so those are still, stay tuned, still to come, the answers that we hope to have in the next several years.
I think the systematic review, which Eric did and was nice enough to allow me to help with, it shows really definitively that repair is here to stay, and it's a legit option. I mean, I think that for a long time, as repair was shown really definitively by Dugas to be working well, there were kind of naysayers that would stand on the podium and say, well, reconstruction is the tried and true, and you should be doing reconstruction for, your highest leverage athlete. And I think it's hard to say that looking at these results. I mean, I think you look at these results and it shows that repair works very well. So obviously, again, it's not for everybody. There are tissue deficiency patients, but I mean, the results are they're self-evident in the systematic review. I mean, it's hard to really argue against with these results. You're on mute.
Thanks. So that's fascinating. So talk to me about Eric mentioned a little bit about how he selects on who's the best candidate for repair versus reconstruction. Maybe do you want to expand upon that? How are you making that decision? Is there a way to identify potentially earlier on so you have better tendon quality versus people that are maybe a little bit more later, a little bit worse tendon quality? Like what's your repair population?
Yeah, I think is that question for me or for Eric?
Oh, sorry, Peter. Yeah, sorry. Peter for you, and then I'm going to go back to Eric with a similar sort of follow-up.
Yeah, our group did a similar study looking at the indications for repair, and there's some agreement as to who should get a repair, but I think this is a source of continued controversy, and certainly something that I think we're going to be looking to address with the work we're doing going forward is, are there differences in who does well with repair versus who doesn't? Obviously, because so many patients do well, you need larger numbers to really tease that out. But we've really come to understand that in the ACL. Like in the ACL, for instance, there's much better understanding for things like tibial slope, things like what age is the patient. Maybe if it's a female that has this particular knee anatomy, you're like, oh, this is a really high risk patient, and we're going to add a Lemaire or something like that. I think that we're going to get there with the UCL, but it's harder. There's lower numbers, and you really have to combine your data to find those kind of things. For me right now, I think that more acutely, it's easier to do the repair. That doesn't mean that I haven't had chronic patients that I've been able to repair, but as they become more chronic, it becomes more problematic. Just to be frank, this particular injury, there are fewer patients that come in chronically. And I don't know how they all know that, but there's just not that much tolerance for, at least among my community. I've spent 6 months waiting to return to throw. Usually it's been 3 weeks and they're like, I cannot throw and I must do something different. And this feels different than the other times where I've had a tweak in my elbow. So if those patients have a full thickness tear, especially depending on what time of the year it is, we tend to be more aggressive with them surgically because it's more likely you can get a repair done earlier on. What are your thoughts on that, Eric?
The same. I would say that as patients are becoming more keyed into this, they are coming sooner, and yeah, they're not able to throw after 3 weeks, and then they want something done because they see their friends doing well, and they hear about people getting the repair, and so they come in asking for it. Actually, I found more often. I mean, and this is a huge kind of shift and I think in the culture in general is that when I came out in 2018 or so, I saw maybe a repair or two in fellowship. And then I would say now probably 90% of what I do are repairs. And I think that's in large part, one is the patient population I take care of. And then two is that, yeah, if you have a full thickness tear, I think you're going to take care of that quicker. And as kids are throwing harder and all that, I think we're seeing more of those tears sooner. These avulsions essentially that they're very repairable and they do very well.
Kevin Dunn asked the question we all want you to answer. At this point, why would one ever perform a UCL reconstruction without an internal brace augment? Too many holes in the bone? Can the hybrid reconstruction with the internal brace have the same rehab as repair with internal brace? Maybe we'll start with you, Peter, and then go to Eric next with that question.
I think it's a great question. And I think it's a legitimate one to say, wouldn't you just want to do wouldn't you want to add the tape to every single one of your reconstructions? I think there's a couple of reasons why not. Reason number one is because it does place more stress on the bone to put something that's more rigid like in between the two bones. So concerns about that are, number one, you can create a fracture risk, and I've had one fracture with an augmented repair. It's the only fracture I've had, a medial condyle fracture, where I've worried that it was because of the tape. Reason number two, I think, is that what about the laxity within the joint? If you look at the first study we did, one of the things you see is it is normal for there to be laxity in the joint, and more laxity is associated with higher velocity. So that shows that there may be some normal stretch within the elbow, and reducing that stretch to zero may not be a healthy thing for the elbow. That's normally not what we think of in joints. Normally you think of in the joint, laxity is bad, movement is bad, you don't want any shear stress across the cartilage, but I'm not sure we really know that to be true. So that's one reason that I've worried about. And then the last reason, and this I think is probably the most important, is, we did a biomechanical study at my own place looking at the way that I do a UCL reconstruction with no tapes, and it is biomechanical equivalent to the native UCL. So I understand people saying, I want it to be the stiffest, I want it to have the highest load to failure. I'm not sure I want that. Like, I think I want it to be as good as it was. And if I can get it to be as good as it was, but with more tissue, that should be the normal elbow. So maybe I'm wrong, but I'm not sure that more is always better. But I will say the field is moving that direction, that hybrid is everything,
Eric, what are your thoughts? Are you doing hybrid ever on reconstructions? And what's the negative in adding a tape?
Yeah, I'm switching over to doing much more of the hybrids. But the points that Peter brings up are very relevant and always in the back of my mind. We're not going to know the answer to this for a few years until this has become pretty widespread. I would say if you asked this question a year ago, probably half as many people were doing with the augmentation. So it's really taking off. And yeah, we're going to see, is this going to, you have a tape in there and a graft, is that going to abrade the graft? And then you just end up with a worse problem down the road. We don't know. And I think that those are the answers we're going to find. But I think that as we continue to increase velocity in particular, that we're going to be stressing our native grafts as, our reconstruction grafts a lot more. I think that one of the trends you're going to see is that, you used to say, well, you get 7 years out of a Tommy John. I think that number is going to, if you just do it without tape, potentially come down. Maybe the tape kind of mitigates some of that. But I think that we're going to probably see an epidemic of re-tears as well at the higher levels, just given the velocity. So I don't know. I'm just saying I'm moving towards doing more of the reconstructions with the tape. But I might be putting myself out there to do that.
Eric, I asked you a question. You brought it up. If you have a revision, are you using a tape? What's your thought process to handle those patients?
Yeah, I don't have a heavy revision population, but yes, and a lot of revisions, Peter, you may be able to comment, are actually more the avulsion types, and so those are very you can repair those with a tape oftentimes. I like that technique.
Yeah, it depends a lot. The revisions are mostly humeral sided, which is very interesting because most of the primary tears are ulnar sided, which is strongly suggestive there's something we're doing wrong. And there's thoughts about that. There's theories. I don't think anyone knows for sure, but some of those are amenable to a direct repair, which is really nice. If you can repair the reconstructed tissue back and get it to heal, that's much easier than trying to say, I'm going to cut all that out and put in a whole new graft. That's kind of a miserable operation. So that's the new kid on the block, is repair as a revision technique. And I think its numbers are small enough, but on that it remains to be seen. But Keith Meister has done probably the most and claims that it works quite well. I've done it a couple of times and it works, but I don't have a large enough experience to be like, you can do this every time,
Awesome. Can you, Eric, maybe on this, Peter kind of hinted at this a little bit, but can you make the tape too tight? Like, can you make it so they lose some velocity that gave them the velocity, and thus actually impact their return to the level that they were at before?
I don't think we've seen that, but maybe I don't want to steal this from Eric, but there's another biomechanical concern with that you really can't evaluate in the lab at time zero. And it's hard to discuss, but let's say that when you do your reconstruction, you repair the native ligament, and then you put a graft in, and then you put a tape in. Now you have three separate entities, right? Native tissue, reconstructed tissue, that's theoretically devascularized, and tape. How do you tension those three tissues? Like, what's supposed to be the most taut? The native tissue? How do you tension them differently? To tension them differently, you'd have to probably fixate them differently. Now you have three fixation points on the meetup condyle. So, or on the sublime, which is like, there's not a lot of real estate in either of those areas. So I think that's real. I mean, if you tension the tape, theoretically, are you stress shielding your devascularized graft? What happens to that tissue? In our prior ultrasound study, we showed that historically with reconstruction, when we look at those patients later on, their UCL is twice as thick as a native UCL. And if you look at a lot of MRI images of traditional UCL, that's what you'll see, a lot of tissue. Is that going to look the same when we add a tape 5 years later? I don't know. But I mean, I think that's to me, these are like unanswered questions that are difficult to answer in the lab.
All right, there's one more question I'd love to ask before we move on. This is so fascinating, guys. Great conversation. The return to play for UCL reconstructions versus repairs were quite different in this paper. Can you comment on why you think the repairs returned quicker versus reconstructions, and why the return to play is so different? Maybe we'll start with Eric, you this time first, and Peter next.
Yeah, and I think it's an interesting question because I've kind of thought that myself is and I think the tape changes it because I think that we at least we think that it's going to protect it. Maybe we're not right there, but it does seem that we push it quicker when you have the tape in there. And I think that the reconstructions with the tapes are probably pushing it a little bit more as well. With a repair, you don't have as much area to heal, I guess, is one reason potentially. And most of these kids, they're throwing around 10 to 12 weeks, at least kind of starting the throwing program. And initially we said, well, six months, you probably get back to pitching. I would say we're actually kind of lengthening that a little bit to give them a little bit more time. So it's really more, 7, maybe, 8 or 9. It all depends on kind of the time in the season. But I try not to rush them through it either. I try to go slow so we don't have start and stop type situation. And then if you look at some of the rehab protocols for reconstruction now, they're actually they're bringing that time down to, closer to 9-10 months maybe. So I think that we'll probably have sort of this continuum where repairs a little bit quicker, reconstruction's a little bit longer, but they're not quite as extreme as they once were, is my thoughts. And we're working on sort of our rehab program now that takes into account workload and all these different factors that I think you need to think about rather than just go out and throw 20 pitches today and 30 tomorrow type situation.
That's awesome. Perfect. Well, so let's move on to the next one so we can get to it and then get to our last one. So the next one's the OCD paper, fresh osteochondral allograft transplantation for Capitella OCDs. This is sort of the background of this swinging pendulum as we just found with the UCLs of treating these with microfracture to considering different osteochondral grafts. There's a decent amount of literature on these autograft osteochondral grafts, but this is sort of one of some of the emerging things on the allograft. So the evaluation is a single surgeon case series of allograft osteochondral transplant for OCDs. It's done via mini open approach, ligament sparing. Pretty good overall numbers. 35 patients, 24 of them were baseball players, 5 gymnasts, 3 cheerleaders. So relatively high level athletes. And there was a single plug that was used in 23 patients, 12 that required 2 plugs. And overall, the mean flexion contracture was 14 degrees. And then, and the age was, these were teenagers for the most part. It was 16 years old, mean age, the oldest patient was 32. So the follow-up was pretty good. It was 92 months, minimum 24, all the way up to 204. The good improvements in range of motion, their Curly and Jobe orthopedic clinical score also was was pretty reasonable. And of the 46 that got post-op MRIs, at a mean 32 months, there was a very high rate of graft incorporation, as well as the overhead athlete's ability to sort of return to sport. So there were 2 reoperations, both for loose bodies, but in general, pretty nice study showing that osteochondral allograft that's done similar, that's emerging in knee and some other areas of body, it shows that for these unstable OCD lesions, that there's some potential with this. There's obviously some advantages over autografts, and when you're considering microfracture or debridement versus this, there's some clear, maybe clear benefits over the long term. So maybe Eric, we'll start with you. When you have a patient that has an OCD, an unstable OCD, overhead athlete, or just any type of athlete, I guess at this point, what are some of the important considerations as you're treating this patient, and maybe talk to us a little bit about your decision-making algorithm.
Yeah, so for me, the first thing I want to know is, well, how long have the symptoms gone on? What have they done to treat it so far? And then it really gets down to, is the lesion stable or not? I think if you have a stable lesion, you're going to treat that conservatively, as give it a good long, it may take 3 or 6 months. You have to tell the patient up front, or else they're going to be disappointed at a month when they're not pitching again. But in general, if it's stable, I'm going to try to treat that conservatively for as long as I can. If it's unstable, then I think you're especially if it's starting to you have a loose body, then you're basically committed to doing something. And what we know is that if you look at all comers on as far as treatment, there's not a lot of clinical difference between debridement, microfracture, and OATS. And so and all the studies are there's no comparative studies, and so it's really hard to kind of sort this out. So then you have to go to well, maybe there are certain factors that are going to make this less stable. So the more that it involves the lateral aspect of the capitellum, lateral wall involvement, size of the lesion, those are the things that are going to be relevant as far as if you're going to do a cartilage replacing procedure versus just debridement or microfracture, which in a lot of athletes, honestly, debridement and microfracture, or just debridement alone, do excellent. So it depends on your athlete. Are they loading the joints like a gymnast? You may treat differently than a thrower. And so those are the things you got to think about, I think, on the as far as your algorithm. This is good data for the allograft side. The downside of autografts is that you got to make a compromise somewhere to get that graft. And so I like the allograft approach to this. I think that insurance approval and all those other logistical things can come into play with determining how you're going to treat these, is what I've found. But I think this is helpful data if you are deciding to do a cartilage replacement procedure. We just don't know the true indications, I would say, at this point, as far as one treatment versus the other.
That makes sense, Peter. So, Chris and I were debating between 2 different studies, this one and another one that was actually showing pretty good data on the microfracture and people's relatively high return to play. So talk to us, how are you making that decision, microfracture versus either an allograft or autograft osteochondral transplant?
I think you guys picked the right study. This is a really important study. And hats off to Rafi for this study. I think this is a great study. I mean, the things that are important in the study is, number one, this shows very definitively the allograft works very well in this location. And I'm not aware of another study that has this kind of numbers and this kind of imaging follow-up with allograft in this location. And I think there's been concern. I mean, it's a much smaller area. The blood flow we know is not as good. So this shows pretty definitively allograft works great. So I feel great about this because I have not wanted to go to people's knee or people's rib to get grafts. I think you could look at the study and it's hard to argue we should be using autograft. So that's thing number one, is I think allograft works great. Thing number two is, I think if you look, there were 2 elbows that required a subsequent arthroscopy. And I will say that I have gone to doing an arthroscopy concomitantly with every single one of my open osteochondral allografts, because I had a similar experience where I had to go back for an osteophyte that I had not seen because I'd only done the open approach. So I definitely say, if you're going to do this, do a scope first and then make your open approach and do the allograft. It takes just another couple of minutes, and I think it allows you to make sure you're not missing small osteophytes, loose bodies. And the last thing I would say is that I think you're right that you can get good results with an endoscopic debridement, but I think we all know that the end result anatomically is not as good as what this is. It is not real cartilage. It is not the same radius of curvature. It does not fill in as nicely. And so I know that there's increased cost, but there's not a lot of increased risk or time for recovery with this. If anything, the recovery may be quicker. So I personally offer this as first line for most patients. And when you explain it to patients, like, I'm going to poke it and hope the bone marrow heals it, or I'm going to transplant actual bone and cartilage that's the exact shape and size, most patients are like, why would you poke it? What are you talking about?
Yeah, that's fair. Same considerations for bipolar or radial head lesions as well, or how are you approaching that differently?
I get really nervous when it's bipolar. Have you done any bipolar grafting? There's a picture of one, I think, in here. I've never done that before.
Eric, have you? Or how do you
I
approach
have not.
bipolar lesions?
He mentioned that in this study he mentioned a couple bipolar lesions that he done. I have not done that.
Yeah,
I
it's
think
figure
those,
8. Like, this is nuts. Both sides. Have you done this, Eric? No?
yeah.
Wow. Both sides. It's a lot.
Yeah. A little aggressive for sure. How about based off athletes? I mean, are pitchers, do you approach pitchers differently than you treat maybe like somebody that's not an overhead athlete that has this capitellar lesion?
Yeah, particularly gymnasts who are more load bearing. I'd love to hear what your thoughts are on that.
Yeah, I mean, I would say with pitchers and gymnasts, I think both can really be considered load bearing. I would definitely be more aggressive than this. Than occasionally we see this in other athletes, like you'll see this in football players or weightlifters, or like occasionally just as an overuse injury. And I tend to be less aggressive with grafting than in those two populations, pitchers and gymnasts. Gymnasts in particular, like, I don't, God bless you if you take care of a lot of gymnasts. That is a very difficult patient population. I mean, Chris Clifton is smiling. I'm sure he sees a lot of gymnasts. I mean, they are like, that is an addiction.
No, their parents don't let them around me.
I mean, like, it is very hard to get them to slow down.
My wife's a former gymnast. I can relate. This is it's a religion. So Eric, so then what's your future? I mean, is this taking over? Are we all going to be going towards these osteochondral allografts for unstable lesions? You know, I know I've done my fair share of kind of debridement decompression / microfracture versus this. Without question, this looks good. It's kind of like the DTA of the shoulder, right? It looks really, really good. Time point zero. Is this our future, or what do you see as your the future for this?
Yeah, I think for me, as those lesions get a little bit bigger, and like I said, more lateral involving the lateral wall, I'm going to be more aggressive in doing that. Really small lesions, then yeah, probably just a debridement. Yeah, we mentioned it depends on sport. We just finished up a study that looked at autograft and return to sports, and we know that pretty high return to sport rates, although pitchers did have the hardest time with autographs even. So I think you have to counsel patients that, yeah, you probably get back to sport. There's a chance that you may not perform at the same level. So I think when it comes to return to sport, you have to mention that up front.
Yeah.
The last thing, 2 things to say are, number one, we just had, we just returned from the annual meeting where Bob Hotchkiss from HSS presented his long-term results with autograft. One of the things that he said that really struck me is he said when they called patients 10 years later, there were a fair number of patients who had forgotten they had the operation. Literally had no memory. They were like, surgery on my elbow? I don't remember that. And they're like, oh yeah, I have a scar here. I didn't even realize. I mean, like, how many there's very few operations you can say that about, right? I mean, like, maybe you guys have patients that, like, none of my shoulder placements say I forgot I had shoulder placement. It reminds them still on a day-to-day basis because it's still not quite the same shoulder they had when they were 18. The second thing is, I think that the next level of improvement beyond this is capitellum, right? So he used all knee condyles, and the radius of curvature it's good. It's not perfect. So what we've taken to at our institution is I actually requested distal humerus, because if I can get a size width matched distal humerus, it's definitely a different radius of curvature and a better restoration of the anatomy. it's costly, but that's got to be the best that I can provide to an athlete.
Peter, how easy is it to get those?
It's not been a huge problem. There, you have to wait sometimes for them. Knee condyles usually don't have to wait for. These sometimes you have to wait, and then when they come available, you have to use them immediately. So it's harder to schedule. But
And Peter, are you able to size match them? They like when I do the APCs for replacements, they will let me match them by gender, but they like almost never like give me the size data on it or like actually match that. Are you actually able to say, hey, I want something like this width or this, raised curvature, or how detailed can you get that graph?
I just send them the MRI, and then they measure the condylar width, and then they send you a picture with the graph, and they say, we've measured the condylar width, it's this width, and then you check and make sure this is the right width, and then you say, yeah, we want that graph, and they say, great, we have to use it in the next 10 days. But yeah.
Wow, you tell us more high advanced than memory. Koto, you want to go to the last one?
Yeah, happy to. Okay, last one is titled Posterior Lateral Rotary Instability Develops Following the Modified Coker Approach and Does Not Resolve Following Interval Repair. So this was a great study that looked at the modified Coker and EDC split intervals that are commonly used to approach the lateral elbow. Iatrogenic injury to the LUCL may result in posterior lateral rotary instability, also known as PLRI. This study used 10 matched paired cadaveric specimens that were randomly assigned to the Coker or EDC split approaches. All specimens underwent evaluation of pre-dissection, post-dissection, and following repair of the surgical interval. All specimens received the lateral pivot shift maneuver. Radiographic capitellar displacement was evaluated with the full extended hanging arm test and on the lateral elbow 30-degree flexion radiographs. All of the Coker groups specimens developed PLRI in the pivot shift maneuver following dissection. No EDC split group specimens developed instability. The full extended hanging arm test showed no difference in radiocapitellar displacement between the groups. Lateral elbow 30-degree flexion groups, radiographs in the Coker group showed an increased radiocapitellar displacement following dissection compared to pre-dissection. So following repair of the Coker interval, the radiocapitellar displacement remained greater than the pre-dissection. In the EDC splitting group, there was no difference. No differences were detected in the radiocapitellar displacement on the lateral elbow radiographs with either the fully extended hanging arm or lateral elbow 30-degree flexion positions. So in conclusion, this study found that the Coker group produced PLRI that did not return to baseline conditions following repair of the surgical interval. The EDC splitting approach did not cause elbow instability. So Peter, what does this study mean? How does it change your practice?
I think what this study means is that I didn't understand how to do the Coker approach. Like when I look at figure 3B, is that how you guys have been doing the Coker approach? I've been doing it wrong. I've been doing it wrong all this time. I thought it was supposed to be behind the LCL. I didn't realize the Coker approach was in front of the LCL.
Apparently right through it.
Apparently.
It's funny. I've been like pretty much what I've been doing is doing dissections with our residents every rotation. Every time I'm a new resident, we go to the lab and we do dissection, try and teach them the anatomy, and I try and show them these lateral elbow approaches. And I've been teaching them that the Kaplan approach, the EDC split, is in front of the LCL and the Coker is behind the LCL. And that's not what these authors thought. So I think I'm probably just wrong about what Coker meant, but I've been trying to teach people because if you look at that, if you look at 3B, like the entire LCL is cut off of the, like this is, the entire LCL has been recessed off the humerus.
Yes.
Right. So it's like no surprise that then the elbow's stable.
Sure.
But didn't resolve with the interval closure, which is weird.
Well, it's because it didn't. Yeah, sure. Okay, fine. I don't like, how does this get into JBS? What am I missing? Right? Like, is this? Maybe I'm just not very good at elbow surgery. Chris, I mean, you were trained in hand surgery. Like, you've got to be better at these elbow approaches than I am. Did you? What surgery are you doing for that approach in 3B?
No, I bag the LECL every chance I get. So you can fix it. It's
All right,
all
so you're
baseball
teaching-
players.
So you're teaching these residents Coker versus Kaplan. When are you telling them you're using the Coker? When are you telling them you're using the Kaplan?
I tell them I use the Kaplan for basically everything, and I tell them the Coker is really only used for LCL reconstruction.
Yeah.
I totally agree with that. Yeah.
No, that's fair. What about you, Eric? So when you're doing these approaches, regardless of whether this Coker is correct or not, like, if you ever using the Coker, when you are approaching the LUCL, how are you approaching it? How are you identifying it? How are you protecting it? How are you repairing it?
Yeah, so I don't do a ton of lateral sided surgery. I would say that yeah, mine doesn't usually look as aggressive as that they had in the photo there. Usually I'm using it to fix the lateral complex. In general, the things that you remember are, stay above the equator, right? So even arthroscopically, if you're doing work in there, you got to stay above the equator, or else you get iatrogenically injury. I mean, that's one of the reasons that or one of the things that they talked about is the high rate of iatrogenic injury. So I think one is just knowing the anatomy and knowing where it is. And then, if yeah, depending on what pathology you're approaching, you either go above or below is the way that I've always kind of thought about it. Um, I don't know, maybe we should start doing internal braces.
So that's actually my next question. So the athletes, sticking to the theme of athletes, the athletes I've seen that have this are usually like jujitsu or CrossFit or something like that that get this PLRI. So when you are stabilizing that, I feel like the internal brace has really taken off in a lot of the trauma literature in the kind of terrible triad or post-traumatic stage. Are y'all using internal brace? If you're dealing with an athlete that has a PLRI, how are you reconstructing this? Are you using one of the original O'Driscoll reconstructions? Are you, or are we moving in this direction as well, just like the trauma literature to augmenting a lot of these repairs / reconstructions with the internal brace? Peter, maybe do you want to take that?
I have used the internal brace at times. I've been nervous to use it here. One of the things that I get nervous about with the internal brace here is I worry about abrasion against the radial head. So it really has to be above the capsular side, or abrasion similarly on the capitellum. The thing with the internal brace is that when I do a UCL, like I'm really, really confident about where those tunnels go, and how to make them isometric. And I worry in this location that it's harder to get the tunnels to be isometric. On the humeral side, I think that it's harder to get that tunnel in the right spot. I think that's the hardest part of that operation, is getting the tunnel exactly where you want it. And I've worried that if my tunnel is not perfect, and if my internal brace is not perfectly centered with regards to the center of rotation on the curvature of the capitellum, that that either it's not doing anything, or that it's over constraining the elbow and limiting motion. I don't know. I mean, so I've been nervous to use it. I've overall had pretty good results just using grafts with lateral element reconstruction, and I'm using kind of, I don't know if O'Driscoll's the one who described it. He probably did. He described everything in the elbow. So I'm sure whatever I'm doing is something that O'Driscoll described originally. But it was taught to me by Mark Cohen. I mean, Mark Cohen was the one who taught me how to do LCL reconstruction. He was just like brilliant at it. So everything I do on the lateral side is exactly what he taught me to do.
That's awesome. Eric, anything to add on if you're approaching these athletes, anything specifically you do from the lateral side? I realize it's not near as common as the medial side. It's kind of, we spent more time on the medial side of this journal club, but anything else to add on the LUCL or the lateral side?
Not really. I think Peter hit most of the high points there. I think, if it's sometimes you can get a direct repair. Otherwise, if a lot of these are kind of chronic and you're ending up doing a reconstruction, type situation. So, yeah, I think a lot of it just depends on what type of athletes you're seeing and if it's acute versus chronic, but not too much more to add to that.
Perfect. All right. Anything else y'all want to give as advice to all of our aspiring elbow surgeons, elbow sports surgeons out there that are listening to this? You already kind of talked really nicely how to build a practice, but anything else? This is these are some hard problems to take care of. So maybe a young surgeon that's just starting out and sees maybe one of these athletes show up in their office. Maybe I want to give each of you want to give some advice, and then we'll wrap it up.
Sure. I think it's a rapidly evolving field, especially with the UCL. I think that each year you're going to see new data come out, and so I think it's important to stay up on it. If you have a patient that comes in, get a cadaver, get to a lab somewhere, practice some of these techniques. Peter taught me a technique, and so I tried it in the lab, and there's different ways to do the same thing. So find a one that's reproducible for you and that is going to work well for you.
Great job moderating. Eric, Chris, I mean, this is really, it's hard to do this, to like keep the energy up for an hour through this much sports elbow. So great job, guys. I think the thing that's been the most useful to me is I've just been so fortunate to have mentors that are like willing to share what they've learned about the elbow. The elbow's hard to learn about. I mean, it's not, and I think there's a lot of people out there that are, like don't know as much about it. And so I've just been so fortunate to have good people to learn from. So I think the elbow is definitely something where like, don't hesitate to like call someone up, say, can I come visit you for a day? You can learn a ton that way. That's for sure. I mean, every time I've watched someone else do elbow surgery, I've learned a ton.
Amazing. Perfect. Chris, anything you want to say before we sign off?
No, I mean, Peter, Eric, I mean, great conversation. But being down a man isn't hard easy. So y'all kept it lively and had really intelligent thoughts that are going to change my practice. So thank you for joining us.
Yeah, thank y'all very much. This is fantastic, and I learned, as usual, learned a ton from both of y'all. So keep up the great work. It was awesome having, literally when you start PubMeding athletic elbow or all these topics, it's like Chalmers, Bowman, Chalmers, Bowman. It's awesome. Freehill unfortunately couldn't join us tonight, but he also has done a lot. So it's really, really cool to see y'all pushing the envelope. So congratulations on all the great work you're doing. So
Thanks, guys.
Thanks so
Thanks,
much for
man.
having
Great
us.
job.